Ladies and gentlemen, we'll make a start. We're now quorate. Welcome to Blackpool. Some of you will recall that we've had at least two previous attempts to come here. One was a PERDA issue that meant we couldn't meet, and the other one because people couldn't get here because of the snow. So it's a bit like the Strictly contestants who are delighted to be in Blackpool. Anyway, here we are. That's as good as it gets from me. We have apologies from Adam Janjua, is that Janjua? Graham Burgess, Jane Cass, Neil Jack, Sumatra Mukherjee, Lawrence Conway, Louise Taylor, Andrew Harrison, Dominic Harrison, Simon Burnett and Debbie Corcoran. Are there any others that anybody wants to relate to us? Okay. Thank you. Just to confirm again to colleagues that Andrew and myself and one or two other colleagues were available from 12:30 to meet members of the public who may have wanted to ask for explanations about what was on the agenda and so on, to assist them. Nobody actually turned up, but I think it's important that we point this out, particularly that we're now being live streamed and that other members of the public who are seeing us online are aware of that. So we do make efforts to make ourselves as available as possible. There will be a short opportunity at the end of the meeting for any questions that any members of the public who subsequently turn up might want to ask. That is, if any people do turn up. We also have agenda papers available, hard copy at the back of the room for people who might want them. Just a few issues about the place that we're in. We are, as usual, being live streamed, so if people are going to speak, will you please make sure you switch on your microphone, otherwise you'll not be picked up on the live streaming. We're not aware there's going to be a fire drill or anything like that, but you can see green signs for fire escapes, and if people want to use a toilet, there is one toilet which is down the corridor, which is down the left side of if you go out the door and down the left side at the bottom there is one toilet. If it's occupied and you go downstairs, I think you have to pay. So there you are. Right, just one item of detail on the agenda itself. Item 8 should say for approval, not just for information. So if you'll just bear that in mind when we get there. Okay. We come on to declarations of interest, and in particular in relation to item 9. Whilst it's an individual's responsibility to make their own decision on this matter, I think it would make sense for all members employed members or lay members of CCGs to declare an interest in that item. It would not be sensible for people not to be able to vote on that, because we wouldn't have anybody to vote. But it is important when these things are being discussed that people have declared in public that they have an interest in the matter, as I will. So I will invite, if people wish, that they individually make a declaration of interest in relation to item 9. Do all those who have an interest of that nature, are they prepared to do it? Is anybody not prepared to do that? Okay, thank you very much. So we'll record that. And that will include myself. I will declare an interest in that item. I would also declare an interest in items 5 and 6, because I am a member of the Calico Group Board, and they do carry out work in relation to matters which are in relation to care in private care homes and so on. And also are dealing with the CSU in terms of individual patient assistance. Sorry, I haven't got the right title for that, but it probably relates to Jerry's paper. So I will declare an interest because of my directorship of Calico in 5 and 6. Are there any other declarations of interest? Okay, I think, Andrew, that probably covers the introductions, does it? Yes. So, after declarations of interest, we move on to the notes of the meeting held on the 5th of September. And we'll just go through those quickly, page by page. will have I put my papers in the right order. Have you got them to hand?
Minutes.
The minutes, yeah. Yeah, okay. Oh, sorry, they're in front of me. Beg your pardon. Right. Page 1, page 2, page 3, page 4, page 5.
Yes, Chairman.
Page 5.
Page 5.
Sorry,
I'd like an amendment to the minutes, please. The top of page 5. The sentence beginning D. Soper asked for thought on capping individual high-cost packages of care. I'd like the sentence ended at the word care and the rest of it deleted.
Okay, that's fine. People are content with that. We'll make that amendment. Thank you. Page 6. Okay, so are we in agreement with those action notes minutes of that meeting with that amendment? Okay, everybody in favour?
He's coming, but we're not quorate yet.
Sorry, just bear with us a moment.
I'm just... We're not actually quorate yet because there's nobody here from Greater Preston CCG. That's fine. So as long as we don't make formal approvals till Dennis gets
thank
here,
you.
that'll
Right.
be fine.
So I can't ask you to approve that then at this time. We will return to it when we are quorate. Okay. So I'm just wondering if there are any other items which are for information as we're not quorate. We could change the agenda round if that is the case, because Jerry's item is for approval.
My item doesn't actually need to be for approval today. It's more for information.
Okay.
My statutory decision making point of view in March.
Okay, if you're content with that.
Be clear in terms of what's been asked.
All right. And it may be by the end that they're
Dennis
here
will be
anyway.
Joe, if you put the mic on, please.
Okay. Thank you very much. So we will then... I would also ask at this point, are there any other items of any other business? As you know, usually we ask for this so that we can manage the agenda if there's a weighty item coming under any other business. I've not been told there's any. Anybody got any at this point?
I will just give a verbal mention about some decision making with regard to learning disability.
Do you want to do it now, perhaps, or is it quick, or would you prefer later?
Probably later after the commission. Oh, here's Dennis. After the commissioning reform, it would be helpful to do it then.
Right. So if just one item of any other business from Amanda. Thank you. So we'll now move on then to item 5, individual patient activity. Jerry, thank you.
Thank you, Chair. As you will all now, I think, hopefully be familiar, this is the latest instalment with regard to individual patient activity. I will use the abbreviation moving forward, so forgive me for that. I won't be going through the paper in detail, but I am happy to take questions. What I do have is a presentation relating to the paper, which I will use just to highlight some of the key points that are within the paper. I would also just draw your attention to the recommendations here. Under the latest terms and conditions, there we are, terms of reference for the Joint Committee, this committee does have the delegated authority for making decisions in relation to the model for IPA moving forward and for the governance arrangements. It doesn't at this time have authority for the decision on the final finance. That will not be covered here today. The focus for today is around the work to date in terms of looking at how we should structure the commissioning and provision of IPA services moving forward into 2020 and beyond. So just want to be clear with that. Can I ask for a volunteer with the... Good. So hopefully you all have...
It's worth just telling people, in case they find it difficult to read on there, with your agenda there is a printed version of this as well.
Okay. As colleagues will be aware, just over 12 months ago, there was an independent assessment of our IPA services undertaken that concluded that the current service and the provision of services was deficient in a significant number of areas, both with respect to its leadership and its governance, but most importantly in terms of the standard of care that was being provided to those who have access into individual patient services. There was also a significant challenge in terms of the relationships, both between the CCG and our providers, between CCGs themselves and between the CCGs and the local authorities. Over the last 12 months, we have worked on a programme of work with two major themes. One was looking specifically about improving the current level of performance, and the second was to look at a new model of provision for IPA services moving forward. The report provides a fairly strong and, I believe, a difficult message around the current level of performance that continues to be extremely challenging. I'm happy to answer questions on that within the paper, but I do want to focus on looking to the future, on our emphasis on how we actually turn this around in terms of improving the standard of care we provide to our population. And I should equally say, as is becoming increasingly important, the experience our staff have in trying to provide what is a very challenging area. Right the way back to those that recall in the beginning of the year, the IPA Programme Board set out its expectations and ambitions for the future service. The first and foremost one was that people who access IPA services do so at a very challenging time in their lives. Very often the individual in question is facing very challenging, complex healthcare needs, health and care needs. It's also a very stressful and difficult time for families as well. Our service at the moment is not presenting a great experience for our families and for our patients and for our population. So one of the clear expectations is whatever we do with this service, it has to offer a better service to our population. We also recognise that the service at the moment essentially is being provided or commissioned by 8 different CCGs in partnership with our local authorities, and it is being delivered by 6 different providers across Lancashire and South Cumbria, which in itself creates a scale of fragmentation which is not surprising that the net result is not something that we should be proud of in terms of our population. So we set out 6 high-level, broad ambitions in terms of the future service, which has underpinned the work we've done over the last 6 months. In looking at how the service should be provided moving forward, it has been a core element of the work of the Programme Board to actually work with NHS England's CHC, FNC Improvement Board nationally, and the work that we've undertaken has coincided with the development and publication of an NHS maturity matrix for the provision and delivery of IPA services. This has been the absolute foundation for how we've looked at how the service should be commissioned moving forward, and forms the foundations for the recommendations. I'm not going to go into the detail of what's in that matrix, but it covers everything from frontline, patient-facing services, how we should interact with families and with patients, through to how we apply the NHS continuing healthcare framework, to how we approach commissioning of services from the provider market, and how we actually manage what is in itself a very complex market. One of the first exercises we undertook was to use the maturity matrix to benchmark how our existing services are provided. Now, at the moment, we have essentially 3 different models of provision. Services that are provided here through Blackpool CCG as an integrated service between the CCG and the local authority. Services that are provided by Midlands and Lancs CSU. And then we have services also provided by a range of different community providers. The graphic up there, the red line at the top, reflects the national expectations where a service provider should be. The work we've undertaken has concluded that Blackpool continues to be the model most consistent with the national maturity model. It also reflects that it is the one area in Lancashire and South Cumbria that is actually delivering, without doubt, the best patient experience at the moment. But in itself is not a perfect delivery model. The Blackpool model also has challenges around economies of scale and some of the digitalisation and the support infrastructure in itself reflects that a small service can be very good in terms of patient experience, but is always at risk in terms of business continuity. Conversely, and again not unexpectedly, our community providers who tend to provide the service outside of their core service areas tend to be the areas where we are delivering the worst patient-centred care today. And that is particularly the case in Morecambe Bay and in Pennine, which is where we see currently today the most challenged performance. Thank you. The challenge always with maturity models, templates, best guidance is they give a theoretical idea of what the best way of working should be, but there is nothing better to compare to than real life. And again, working with NHS England's national team, we have looked around the country at where, both from a performance perspective, from a staff satisfaction perspective, but most importantly from a patient perspective, the provision of IPA services is deemed to be exemplary. There were a number of areas we looked at, Blackpool obviously as I've reflected to, but particularly Surrey Downs and the Cheshire and Wirral models. Surrey Downs has formed a particularly important part of the work we've done because they have been very forward-thinking in two things. One is looking at how their IPA services operate within an ICS footprint, but equally and also more importantly, how it works in terms of integrated care, both at ICS and at an ICP and neighbourhood level. And we have worked quite closely with them to look at their model. Like Surrey Downs, and like we have indicated in our ambitions for the future, there is a really, really strong focus that CHC should not be a reactive, responsive service, but part of very much a proactive community approach to managing people with complex care. This is most evident when you look at how places like Surrey Down have managed end-of-life care. So they have very low levels of fast-track discharges for hospital, but very, very positive, high-level community approach towards end-of-life. And in simple terms, people there don't have to go into hospital to access end-of-life through fast-track CHC. They're provided and supported in their community and never get into hospital. It's an exemplar model which I personally have reflected on very strongly as a learning point. So, taking the maturity model, taking all the best practice that we've looked at, looking at performance across the country, the paper today proposes that we move from 8 individual CCGs, 6 different providers, poor performing model to what essentially is a single business unit that takes an end-to-end approach to the management of IPA services. But it absolutely reflects the ambitions and the heart of the work we've done at the ICS, which is that it has to support subsidiarity. It has to support care being close to the community while using an at-scale approach where it creates value. So it is a combined approach of a single business unit at its hub, providing all the specialist support, providing the financial support, providing a single point of access, but the patient-facing end of continuing healthcare, FNC, IPA services would be delivered through our 5 MCPs, ICPs. So it is a mixture of a hub and spoke model. As it says there, single business unit responsible for all the commissioning and development of IPA services, including a key element, which is a weakness in our current system, our provider market management, which is very much our relationship with care homes, with the 5 spokes responsible for patient-facing services, increasingly developing a proactive management approach through our ICPs and neighbourhood teams. The model itself is simple in a graphical form, but I do stress is a very significant change to the way that we operate. Not only is it a significant change to the way patients will receive their services and families will experience the service, but it will require a significant change in the culture and behaviour of the staff who currently provide the service. I'm not going to go into a huge amount of detail. It is there in the presentation, but we have worked with our peers and we have been out to each of the ICP areas to work with them, to work through and to stress test what will be done in the hub and what will be done in the spoke. Again, I'm not going to go through this line by line. It's there in the presentation. I'm happy to answer any questions. So there we go. The presentation today has focused on the case for change and the proposed model and approach moving forward. The business case, which will come in March, will present the economic model and the resource model that support what's being proposed today. So this is a 3-phase approach. You've seen the case for change twice and been reinforced. You'll see the proposed model and approach today. When we come back in Thursday, we'll bring the conclusion of that 3-phase approach, which will present the economic and the resource case with it. Just as a sense here, very, very clearly now evidence-based, both in the work we've done with our peers, but also the work we've done with NHS England. There is an absolute inverse relationship, and I don't think this should be a surprise, between the level of investment in the provision of the service with the cost of the care packages. So if you invest in a good quality service that's very patient-focused, delivering the right care in the right place at the right time. Sorry for using the famous 3 R's description. The upfront investment in the service ensures that actually we get a better, more productive, more efficient and a more caring service for patients. The business case will bring a much more detailed analysis around that in March. Finally, just to reinforce again, the approach we've taken, the proposed business unit and model of delivery in terms of the hub and spoke is foremostly driven by a real desire to improve the patient care and family experience. And if you've read the paper and the latest performance position, it should leave you with no doubt that as an area, we are not delivering the right sort of service to our population. The proposed approach will actually set Lancashire and South Cumbria in a very good position to continue to build off its actually already positive position around personalisation and personal health budgets. It will really start to strengthen our relationship with the care home market, residential care home, working with the local authorities. It will reduce the scale of fragmentation we currently see at the moment. And it is a commitment from the programme board that if we take this work forward, the current extremely poor standards of performance we see across Lancashire and South Cumbria, with the exception of Blackpool, will be addressed through this work. Roadmap. So this has been a progressive programme of work through this year, building the case for change, building the model. This is an indication of the likely roadmap. So the intention is subject to the Joint Committee and the governing bodies approving the business case from March. We would move into a mobilisation phase. Our ambition and intention is that if we get support for this, that the business unit should be operational from October of this year, moving into fully substantive form from April 21. I'll just put one really important final comment there. In this approach, we have worked in real strong partnership with all of the local authorities. However, with the exception of Blackpool, we have recognised that integrating an approach where one part of the system is fundamentally broke is not a great approach. So we have, with the agreement of the local authorities, focused on getting the health component right, to then allow us then to integrate more successfully with the local authorities. To be really, really clear, the most successful approaches are fully integrated health and care approaches. But we've been very clear in the approach we've taken that in the next 18 months we need to fix the health component and the NHS component, which will then give us a really solid foundation to allow us to integrate with the local authorities, which is the ultimate ambition. So I will finish there and pass back to the Chair. Thank you.
Thank you, Jerry. Thanks. I think that's very clear. Any questions or comments? Doug.
Thanks, Chair. I welcome the paper. I think it's the right direction to travel, but I do have some worries about what this is going to cost us. If you take the Blackpool model, it currently costs 750,000 for dealing with a population of 170,000. And the Lancashire CSU service actually deals with 10 times that number of population. If we extrapolate the 750,000, it becomes 7.5 million. The current CSU service costs 4.4 million. If you take some economies of scale out, it still looks like we're going to have to put a couple of million to get it up to the same level. Is that your view on it? And if that is the case, where are we going to get the staff from to do it?
I am not, so two elements. First of all, I remind everybody to look at the standard of service we're providing outside of Blackpool. So it would be remiss of me to say in any respects whatsoever that if we are going to deliver a good standard of service, we are going to have to invest in this. The total cost of the service itself in Blackpool, when you take into account both packages of care and the cost of the service, is more efficient than a number of the other areas. So again, back to my earlier slide, the investment up front in providing a good service to a population does have an economic benefit in terms of the cost of care to the population in total. That is something that we are trying to work into the economic model. I think that ultimately my view will be there will be a compromised position or a balanced position in that there will need to be upfront investment which will probably be greater than the total amount of savings we generate, but we will be delivering a substantially better service to our population. And we will have to have a decision whether this is an investment that is in its entirety of greater benefit to our population than some other areas, and we may have to be more challenged in terms of where we find savings to support this. My key message for me is that it would be untenable for this economy to carry on delivering the level of service it's currently delivering.
Yeah, and I accept what you're saying. I just wonder whether you've given any thought to how long it will take to train and develop the staffing capacity to deal with the change you're talking about, because you're not going to be instantly available, these people, with the knowledge that you require.
Yeah. So just to confirm and to answer that one is clearly by what I've put up on the slide there will be a phased introduction. So the phased introduction will reflect a phased growth in the costs. So it's not going to be a large sum of money coming in on day one. We are challenged that one of the challenges in this service is recruitment of the specialist nurses and the support team. So this will take 12 to 18 months. And part of the conversation I've had with NHS England itself is the need to recognise that we are not going to be able to address some of the challenges we have in a short period of time, because we will have to recruit the specialist teams that we need to deploy over a period of time. So I think this will be a phasing and ramp up over a 12 to 18 month period.
Thank you. Anybody else? Jeff.
Thank you. Jerry, I thought that paper was really clear and really helpful. It's just understanding a bit about the model. So the hub, is that a virtual hub or a real hub? And if it's a real hub, is this a model for other delivery of other business lines within the ICS? And does it have any implication for how we work in the future in a managerial sense?
I'll be careful on that. It's not virtual. It's a real hub. So things like financial expertise, contracting expertise, the provider market management. These are all skills and expertise that we should have consolidated once, supporting out to our 5 spokes. So it is a real team, as will the staff on the front line in the 5 spokes also be real teams. Is it a model that we could apply to other areas? I think the potential is yes, but I think in all of our commissioning and provision areas we need to work through to make sure that it is the best model and value for money. The one thing I would say is IPA services is the one, as far as I can think, the one unique area where CCGs are currently responsible largely for both the commissioning, the eligibility criteria and the provision.
Thank you.
Okay, Julie.
I just want to say this is a really good piece of work and we should thank Jerry for doing this. Most of my complaints are about CHC and the quality of the service that individuals have received and the distress this causes the families. So I think that if we can actually start to make a difference there, that's really positive. I think the second thing then is that the staff are at the front line in those complaints and they too then, that's why they burn out and we're having difficulty in recruiting. So I think the proposal is really positive. I think we should really support it and try and implement as quickly as we can. The only point I would make though is where personal health budgets are in there and how we can start to really think about how as part of the IPA thing we can start directing that more strongly because that will make a really big difference in general to what we're spending.
Thank you.
Okay, is there anybody else wishes to speak? No? So we have 4 recommendations which are largely to note the direction of travel and I think as you indicated Jerry earlier there'll be in March a business case coming back. So there are 4 recommendations which are really about noting really what the direction of travel is. So are we in favour of that? Yes? Anybody against? Thank you very much. I would just say to the ladies just come in, if you want an agenda, there's a full agenda at the back on the table if you'd like to take that. Thank you. So we move on to item 6, which is regulated care sector residential and nursing care service specification, and Steve is going to help us on this one.
Okay. Thanks very much, Chair. Blackpool's been taking the lead for some years now on regulated care. We've obviously been very concerned about the sustainability of the market, and Blackpool being such a small geographic area, it's something you can't do in isolation, and I think if the ICS weren't established, it's something we'd reinvent for this very purpose. And Karen Smith has been leading on the main work stream, but alongside providers who obviously are very keen in maximising the fees, and we've done an awful lot of work working with our colleagues across the other 3 local authorities, and it's reassuring to know actually despite different approaches, tendering, use frameworks, etc., there's very close proximity with fees, certainly across Lancashire, Blackpool and Blackburn. Cumbria a bit different in view of the sort of geographic dispersity and other reasons. But rather than going straight to fees, I think we felt it was important to actually come up with a common specification, a common approach, an expectation of what clients should be receiving. And not just local authority clients, but also NHS. As Jerry was saying, individual patient activity, CHC, FNC. One specification that's common to all, common expectation. So probably early 2018, a subgroup of the subgroup that I chair, which is finance, markets, contracts, was set up with representatives of CCGs, CSU and local authorities. And rather than starting with a clean sheet of paper, we actually tried to pick out the best parts of the specifications that are currently being used. And that was quite an iterative process, huge process in fact, which took about 18 months to get to a pretty mature stage, at which point I brought a paper to the Clinical Commissioning Board in August, which was well received, but the CCB did provide me with a number of pointers, including, you might be interested a bit about this, Doug, about raising expectations on providers themselves about being able to raise fees by not getting the specification right. So we tweaked that somewhat, and in September held at Leyland an event with providers alongside a survey which was very well responded to. We had like 20 odd providers attend this event in Leyland, and you know, I was a little concerned because I didn't know how it would go, and despite reservations from our own commissioners around perhaps being too onerous on providers, the general feedback I got from the providers themselves was that the clarity was very welcomed, and despite onerous parts in places, at least they knew the standards that were being expected. And these were standards from our commission, not standards, for example, that the CQC might require, which obviously are statutory and legal, but made reference to. So the whole afternoon event went really well. We took on board the consultation, and again, it's a great example of true consultation with providers, that the points they were making were actually incorporated in the final draft, which I took again to CCB before Christmas. And it was at that point that it was felt that it would be best to bring the paper here. I think that the full service specification is included, and it runs to quite a number of pages in there, person-based outcome specification, for the Joint Committee here to endorse. I don't think we have the legal powers to approve it, but if you could endorse it and take back to your respective CCGs and ditto the local authorities through their decision-making processes, this would actually fit the timescale to be implemented with effect from the 1st of April 2020. But happy to answer any questions you may have on the process or indeed the detail therein.
Thank you, Steve. We have, I think, 3 recommendations in the report, which are on the front page of the report as well, that members might like to consider. Anybody wish to ask questions or comment? Doug?
Again, I welcome the piece of work, but the one concern I have, and I think there's probably an answer you can give me on this, is this is quite an onerous specification for good reasons. And those where you've got groups of homes, it's obviously a lot easier for them to meet these specifications because at the infrastructure to write the policies and to have the staffing models and that sort of thing. The small operator, I mean, are there mechanisms where the small operator can get some support to be able to deal with these policies? Are they in federations or those sort of things?
Yes, we provide regular newsletters, incorporating training, support, etc. Again, the feedback from the event, which covered a whole range from the Lancashire care associations of this world to individual sole operators, was the general agreement to the process, and we were very happy that we were taking those steps. So I think the providers saw this as having agreed a platform, an expectation. You see that as a precursor to the next step, which is the contracts themselves, because all the CCGs, I think, use different contracts. Local authorities certainly do. And then with a common specification, we could perhaps get some convergence then on contracts and fees and overall monitoring of that.
The one thing I wouldn't like to see is a small operators frozen out because they can't deal with the requirements. I don't know how we can support them if necessary within reason, or whether they've already got self-support mechanisms amongst themselves.
No, absolutely. As I say, there are, I'm just trying to get my hands on it. There is a newsletter actually went out yesterday to all operators, pointing out events that are coming up, support that can be had within the ICS. So yeah, the opportunities are there.
Anybody else on this? Jeff?
Thanks again. No criticism of what's written there. It's just a question about something completely different and how it integrates with this. So primary care network specifications are coming up for discussion at the moment, and one of the first ones is going to be care homes. Now, it's going to be very difficult for primary care networks to deliver on any of those specifications unless the people who it interacts with are required to work with them. So I can't see the care home one being delivered unless the care homes themselves collaborate and cooperate with what the GPs and in the primary care networks want to do. Do you get my drift? So I wonder how far does this go to support that?
Yeah, I appreciate that.
Amanda said she could pick that up if you have a first crack anyway.
Yeah.
So this came up, I think, last time when Steve informally brought the fact that it would need to align in many ways. And we were clear that these were two different pieces of work, but recognise that both would only work in conjunction with the other. And I think it does. It's been taken into account by the group doing this work that the enhanced support to care home spec was coming along. I think actually this helps that and vice versa. This is really clear. The teams offering the health input are really clear about what they can expect a care home to be doing, and increasingly as time goes on, care homes will be increasingly clear about how they access support from health services. So I think the two together should enable us to really make quite a step change in assuring quality.
Well, I think we should make something of that then, because I think the anxiety amongst the general practice community about the specifications. So if we could actually say that, I think would be useful.
Yeah. Do you want to add to that, Steve?
Yeah, throughout the process here, we've been informed what's going on nationally and trying to align the two, ensure that so that the two are consistent. Try to remove any bespokeness that PCNs might incorporate, create that genericity, but at the same time providing the clarity of the specifications. So, yeah, there's a few things to combine, but hopefully we'll have delivered that. But if things come along that are inconsistent with that, then we will need to adjust iteratively.
Is there anybody else on this one? No? Okay, so we have 3 recommendations. Are we happy to accept those recommendations? Yeah, nobody against? Thank you. We move on to item 7. I think it's yes, commissioning policies. This is one of a number. One of the last, I think, that we're bringing along, maybe. We shall see. Elaine, over to you.
Can't promise you, thank you, Chair, can't promise you it's the last, but certainly the latest in a long line, and just the one today. So I will move on to that quite swiftly, but I would like, as has become my habit, to just begin with a couple of introductory remarks about policies to set the context for the benefit of members here, but also for people who might be listening. As we know well, that the NHS has got finite resources and is responsible via CCGs to use those resources to deliver the best possible healthcare for its local population and not to exceed those resources. That, by definition, means we have to set priorities to be sure that we are using the resources we do have in the most effective manner to deliver the maximum benefit to our population and to minimise potentially avoidable harm from healthcare. One of the ways that health systems do this is obviously through the development of clinical policies which describe the circumstances in which certain treatments are made available. We don't have clinical policies for everything that we do in the NHS. Policies are created in circumstances where there's a degree of uncertainty about the effectiveness or cost effectiveness of an intervention compared to possible harms or compared to alternative treatments. Sometimes it's because a treatment is new and we don't have enough evidence to fully understand its risks and benefits. Other times a treatment may have been widely used in the past, but our understanding of the balance between benefits and risks has changed because of new evidence. And some other times a particular procedure may actually have been superseded by a newer procedure which may be less invasive or safer way of treating the same condition in some circumstances or for certain patients. So the 8 CCGs in Lancashire and South Cumbria have chosen to do this work together so that we can adopt the same clinical policies and thereby ensure equity of access to these treatments for all of our patients. We've developed a process to ensure that all of our policies are based on good quality clinical evidence, that we understand the financial impact to the local system of any changes to policies or new policies, and that we consult on draft policies with both clinicians and the general public and take due consideration of any potential equality issues, all before the draft policy is brought to CCGs, and that process is summarised in the paper that you have before you today. That process is managed through the Lancashire and South Cumbria Commissioning Policy Development Group, which I chair, and so that group is, I guess, my mandate for coming to you today with the policy before you is with their recommendation that this policy be adopted. So if I move on to the specifics of the policy, the intervention under discussion today is the use of low-intensity pulsed ultrasound therapy, or LIPUS for short. This is an intervention that actually is subject to an evolving evidence base. So it's one of those places where it's a possible new way of doing something that we've not been very potentially good at in the past. So there's a possibility of a new intervention that may enable us to treat these very difficult to treat fractures, quite refractory fractures, in a different way and develop a potential benefit for patients. And this indeed was the premise which was put to us via a number of stakeholders who were aware that some other parts of the NHS had considered this intervention and actually had a commissioning position on it. And Lancashire and South Cumbria had not done so. So that was the reason why we thought it was useful to have a look at the evidence for this intervention. The development process was the standard process that we used there. What came out through that was when we looked at the evidence base, as I say, it is evolving. It's very much in the remits of clinical trial research at this moment in time. But there is a piece of guidance from NICE, and actually that piece of guidance says that at the moment, the evidence of effectiveness is not solid enough. And so NICE's recommendation is that there is continued research on this basis and that this intervention is only used in that kind of a context. Given that position from NICE and our assessment of the evidence that it hadn't changed since NICE made that statement, the policy that's before you today is a do not do policy at this point in time. And for those reasons, that actually we don't feel it's of proven benefit yet. There's a possibility that we could do this and actually not benefit patients at all. Recognising that it's an evolving situation, it may be a policy that actually comes back to you sooner than the 3 years that we would normally say. But at this point in time, we felt it was appropriate to have a statement on record to say that this isn't something we want to commission. Take any questions?
Okay, any questions on that? I can't see anybody. Okay, so I'm content to agree to that, to endorse that policy? Yes? Nobody against? Thank you very much.
Thank you.
Thanks again, Elaine. We move on to item 8, which is the Lancashire and South Cumbria Medicines Management Group. I mentioned earlier at the beginning of the meeting that this is for approval, not just for information, as it shows on the front sheet. And Andrew, do you want to say anything on this one before we kick off?
Only briefly, Chair, to say that within the scope of the work programme for the Joint Committee, in line with the way that Elaine has just presented commissioning policies, CCGs were also prepared to take collective decisions about medicines policies, and that's the basis on which Brent is bringing the papers now.
Okay, thank you. Brent, welcome.
Thank you, Chair. So in terms of the Lancashire and South Cumbria Medicines Management Group, the context set by Elaine in relation to policies applies equally to medicines. And the Lancashire and South Cumbria Medicines Management Group has been established since 2012 and has been historically a collaborative commissioning arrangements of CCGs. And the intention is as set out by Andrew, is that we'll be looking to bring those recommendations of the Lancashire and South Cumbria Medicines Management Group to this committee in future for collective decision making across the 8 Lancashire and South Cumbria CCGs. In terms of the development of the recommendations of the group, you'll be familiar with the processes used by the commissioning policy group, and that is similar in nature to medicines management. So there's a well-established approach. There's a risk assessment and prioritisation at the early stages. There's clinical review, and following consideration of all of that evidence, the recommendation will then come via the medicines management group to this committee. So for consideration today, there are nice technology appraisals. So there's 2 of those, and then there's 4 local recommendations that have been made and developed by the Lancashire and South Cumbria Medicines Management Group. So my intention is to take each of those in turn and look to agree a position before we move on to the next. So initially starting with the nice technology appraisals. So commissioners and or providers have a responsibility to provide funding for to enable the uptake of nice technology appraisals, and the way that's happened since the Lancashire and South Cumbria group was set up is that all nice technology appraisals are considered by the group. If those are commissioned by CCGs, then a recommendation is made on to support in line with the nice technology appraisal, and then what the appropriate route for patients to receive those medicines. So for consideration today, the first is a technology appraisal for the use of pentastan for bladder pain syndrome. NICE, during their review, didn't feel that would have significant cost implications, in that there are a number of other interventions of similar cost for this treatment, for this condition. When they say non-significant, they generally, their threshold is 5 million per year in England, which is a cost of 9,000 per 100,000 population. So the Lancashire and South Cumbria group considered the NICE technology appraisal, recommended that it should be adopted, given a red rag rating. Now, in medicines management, we tend to use rag ratings to denote where it is appropriate for a intervention to be provided. A red rag rating is that it's appropriate to be provided from specialist services. So the group recommended that it should be adopted in line with the NICE TA with a red rag rating, as in from specialist services. So just take any comments as to whether people are happy to approve that.
So as indicated, there are 5 items here, so we'll have questions on each of them in turn, and then we'll take a vote on the specific one. Okay? So anything anybody wants to ask in relation to this first item? No? No questions? No. So are we happy to endorse that, approve that course of action? Yes? Nobody against? Thank you. Okay.
Okay, thank you. The second NICE technology appraisal related to fluocinolone intravitreal implant, which is an implant into the eye for chronic diabetic macular edema in patients with basically with phakic eyes, which basically means you've got your own lenses in place, you haven't had a lens replacement. NICE reviewed the evidence and the cost effectiveness for that condition. They didn't feel that in patients with a natural lens that there was sufficient evidence to support the use. So NICE recommended that it shouldn't be adopted in that patient cohort. The group considered that and agreed that we should give a black rag rating, and essentially black means that we don't support it in line with the NICE TA.
Okay, any questions, comments on that? No? Are we in favour of that one? Yes? Nobody against? Thank you.
Thank you, Chair. So moving on to the recommendations of the committee that have been developed through the sort of local prioritisation process. Cariprazine for schizophrenia in adults was prioritised via a request from Lancashire and South Cumbria Foundation Trust. That was... there are a number of agents available for the treatment of schizophrenia. However, a number of those, or very few, really target the negative symptoms associated. And so the request was to consider the use of this intervention, so cariprazine, in patients where, as a second-line treatment, in patients who have predominant negative symptoms. So that was the evidence was reviewed by the team and in consultation with Lancashire and South Cumbria Foundation Trust. A draft recommendation was sent out for clinical consultation, and as a result of that, it was agreed that Lancashire and South Cumbria Foundation Trust needed to have an internal approval mechanism. This is a medication that's used fairly second or third line after consideration of other agents. So the acquisition costs, because of its place in therapy, it won't be used in a large number of patients, so fairly small. So it was estimated that we'd be looking somewhere in the region of 15,000 per year, which in medicines management terms is tiny, and obviously for yourselves also, going up to something in the realms of 30k in 5 years. There were a couple of issues highlighted during the clinical consultation phase, which related to the specialist service providing adequate information to primary care clinicians, that patients had received appropriate information in terms of contraceptive advice, and so that was adopted by the Lancashire and South Cumbria Foundation Trust in terms of their approval mechanism. The group recommended that would be an Amber 1 RAG rating. So Amber 1 is appropriate for use in primary care following initiation and stabilisation in specialist services, in line with a shared care document that sets out information that both secondary care and primary care's responsibilities. So that's just for consideration for the Amber 1 RAG rating.
Can I ask it?
Yes.
Thank you for this. This applies to all of them, not just this specific one.
Yes.
I am maybe slightly uncomfortable that nobody, including the clinicians in this committee, has the degree of specialist knowledge required to say whether or not these things should be used. So I think what we actually should be endorsing is that we recognise any financial implications for us as commissioners, and that we almost support that the mechanism, the process we've set up is suitable, and that the evidence that's looked at, which presumably for all of them is going to be, you know, the evidence looked at will be standard for each one.
Yes, yes.
I would
Underlying.
be very, very uncomfortable if anyone in this room put the hand up and said, no, I don't think we should use cariprazine or whatever. Even the clinicians don't have the degree of knowledge. So there's something about, I realise we've got to approve decisions that we make jointly, but I think some of them that we've got to trust that people, and if there's a nice TEA guidance telling us to do it, we need to recognise the implications, but we can't make a unilateral decision that we're going to ignore it, can we?
No, and certainly in terms of the NICE technology appraisals, they are mandated. And in terms of the local developed policies, there is a significant underlying evidence review that sits behind that is then considered as part of that clinical consultation phase. So yes, I would be surprised if there were clinicians in the room that raised clinical issues that haven't been considered either during the drafting stage or during the consultation phase.
Yeah. And even if they did, I'm not sure we should accept them. So I think we just need to be really clear. You know, if Jeff claims to know more about than NICE about any of these things.
No, I absolutely agree with you, but what I would like to know is, because I think what we're endorsing is the process, not the knowledge, which includes the finance and everything else. So what I'd like to know is, was there a disagreement about this, or was there disadvantages and advantages considered, and it was on a
what was the flavour of the discussion? Was it unanimous? Was it close?
Yeah.
You know, what are the issues? And if there is none, just to state that.
Okay. So I think certainly in the context of that particular one, it was really just around making sure that there was sufficient information going back to the clinician around the process had been adequately followed in terms of identification of appropriate patients.
Okay, and can I have one last question just about it? So for a few of these and for other things as we go through various medications, there's recommendations talking about shared care agreements. What is the link with the commissioning of shared care agreements? So some of these will be added into existing shared care agreements.
Yes.
Some of them may not be. Are we really clear about that?
Yeah, so any that recommend a shared care agreement, at the group we will consider whether that's placed into an existing shared care or whether we need to develop a new one. And so for this one it would be added into an existing, but there is always a process to make sure that happens and to make sure that that clinicians are supported with an appropriate shared care document.
Dennis.
Yeah, I'm not going to go into any clinical debate on this, but it's just a broad point which I think applies to all of these. I get the point that lots of colleagues have made about, in particular, around gross budget impact, but it's gross drug budget impact.
Yes.
So I'm assuming that in consideration of all these, there's the impact analysis of a total year of care, quality of care for the people we're serving, including the cost of care for them. So the assumption is, by substituting a lower end drug for a higher end drug, it substitutes greater cost in something else. You don't have to answer that, do you? If that's considered, that's good enough. And the second part to it is, I guess I won't be doing my GP colleagues in Central Lancashire justifying it raises, because I hear it all the time. Whenever I hear the term shared care, it raises some element of alarm bells, saying, well, shared care implies that somebody's going to do something they don't currently do, which incurs time and cost in another part of the system. So that will factor into the overall consideration of whether it should be drug A or drug B.
Yeah, so there's significant GP engagement through the consultation phase, and we also all consultations that would have an impact on primary care go to the LMC for LMC comment, and there's also feedback and discussions at each of the medicines management groups in each of the CCG organisations. So certainly in the case of this, yes, it is a new drug going into the shared care, but the patients that receive this would already be on a drug, so it isn't additional work per se. But yes, we would always consider all of those issues in terms of sort of primary care workload or workload across the interface.
Jerry, yes, and Paul.
Yeah. Thank you, and would certainly endorse the comment about seeking assurance around the process rather than the clinical decision. And it does relate to process that my question relates to. I'm mindful sometimes when we take decisions to make access to drugs or treatments, we have a fairly bold view about what the need will be, but by the very nature of making something access, thresholds start to change, and suddenly a prediction that there'd be a really low level of usage suddenly becomes a much higher level of usage because we've changed the threshold for access. So my question is, it's not clear in here, what is the process to review and over what time scale these sort of decisions? So if we approve this today and it's indicating there may be 14 patients this year and 28 in 5 years' time, what process is just being used to actually make sure that we audit that so that we are confident that any decision made today, that there won't be a significant change to that we're not cited on?
Yeah, so we have a number of mechanisms in place. So for some decisions that we make where we are, where there may be less clarity in terms of the size of the patient cohort, then we would make a recommendation through the group that we actively monitor and bring something back to the group in 6 months to check that uptake is in line with our expectation. We also monitor prescribing trends on behalf of CCGs routinely and quite regularly. And so if there are anything that's identified through that process that has significant growth, then we would also take that back to the group. So there's a sort of active monitoring with particular drugs that we think may have uptake different to our expectation or may have significant cost implications. But then there's also a sort of a regular monitoring of routine data to make sure that there isn't anything that's we thought was going to be a low uptake, but is suddenly a large uptake.
Okay, thank you.
Paul.
Thank you, Chair. Yeah. Just in terms of the questions that have been asked, and perhaps for further clarity for myself at least, who does the Medicines Management Group report to? Which group does it report to? And who signs off its terms of reference? And where do its minutes go, I suppose, so that to that general clarity about the governance process that it sits in?
Yeah, so the group is chaired by Andy Curran, Medical Director for the ICS, and it reports into, so it used to report into the Collaborative Commissioning Board of CCGs, and I think its terms now report into the ICS board.
No, it's ultimately here.
Oh, sorry, it's here.
It's
yes.
here. The Collaborative Commissioning Board does a lot of the work that gets brought here, so it ultimately reports here.
So we've set the terms of reference. So some of the questions were really about what's the group doing.
Sorry,
So we've actually seen those, I presume, in the past. Yeah, that's right. Yeah. Okay. Thanks.
Okay, is anybody else on this, on the more general points? I get the impression from the discussion that's taken place that if we look at the recommendation, it says to ratify the collaborative recommendations. Do I get the feeling that you're really wanting to ratify the process that has been followed to bring these forward, rather than because of the inability to challenge, if you like, the clinical speciality?
So I sort of think we can have the discussion about all of them in one go, because I wouldn't expect individual clinical questions about one or other of these drugs to come. Yeah. If that makes sense.
Yeah.
Okay, yeah. So when we're framing the recommendation, do we want to...
No, we still have to...
Were you happy that it's as written that we ratify the collaborative recommendations? That's okay then, yeah. Okay. So do we still want to take them one by one?
No, I'm not sure we need to.
I don't. No. If I'm honest, Chair, I don't think that there's anything that is significantly clinically or financially contentious at this stage.
Right. So we'll give people then the opportunity to ask a question about each one as they go through, otherwise it'll get too confusing, I would suggest. And then at the end we'll agree them en bloc.
No, I don't think we need to go through detail by detail.
Okay, right. So, okay, Doug.
Can I just make a general point? You might need to take it away and think about it. My understanding is that the shared care agreement, the GP's willingness to partake in shared care agreements vary significantly across the patch. Now, presumably, so at some stage we're going to have to address that issue, because it means some patients are able to make use of shared care agreements and others it resists. I wonder at some point whether you'd be able to analyse how these things work across different patches and give us a base point for taking it forward to get some more consistency.
It certainly is the... there is, as you point out, there is sort of variable support for shared care. Some practices are sort of maybe better set up to manage the patients through shared care. There are a number of discussions at the group about how we can support the uptake. So, for instance, there's discussions around sort of wider antipsychotic shared care at the moment. And so there is actions coming out of the group to try and take things through, things like the Mental Health Collaborative Board, to look at how services are commissioned to support practices. So while we focus mainly on the medicines issues, we will take those into the wider ICS boards or groups as appropriate to try and support practices.
So, Doug, there's two issues with that. There's the patient experience, if that service isn't particularly being offered. And it may be that networks may be able to help with that, because there might be one team member or practice within a network that's happy, has an interest and happy to do that. The other thing is, of course, for people who aren't receiving these prescriptions as part of a shared care agreement in primary care, they're having to go to the hospital, for which there is a outpatient cost that could be avoided for us as commissioners. So it is quite an important point.
Yeah, I agree with you. It sounds to me the sort of challenge we could set some of the new primary care networks to pick up in areas where there's poor support.
In time, recognising that they are maturing and being overwhelmed with asks. But yes, absolutely.
Anybody else want to ask anything generally then about all of these? That's where we've come to. Anybody else? No. So are we happy to agree on block then these recommendations? Yes? Nobody against? No. Thank you very much. Andrew.
Thank you, Chair. So, introduce the last item on the agenda before AOB. There are two elements to this particular item which we've drafted to support consideration and discussion about how NHS commissioning evolves over the next couple of years. The first is a case for change and options appraisal document, and the second are terms of reference for an oversight. And I've asked the Chair if we could present the case for change and discuss that and the recommendations for that, and then move on afterwards, if that's acceptable to the committee as well. As I've indicated in the cover paper for the case for change, this has grown out of a number of workshops that have taken place over the course of last year with chairs, chief officers of CCGs, directors from Midlands and Lancashire, CSU, and colleagues from the ICS as well. And the framing of those workshops has been to talk about how commissioning has been evolving since CCGs were created, which is now 2013. In particular, the way in which CCGs have begun to work collaboratively in partnerships in local areas, rather than pursuing a competition or a market model, as perhaps was originally conceived. And the acceleration of that work has happened particularly since the 5-year forward view was published in 2014. So by this point, we talk very clearly about 5 local partnerships, integrated care partnerships, in Morecambe Bay, Fylde Coast, Central Lancs, West Lancs, and Pennine Lancashire. There are many other dimensions, but I suppose the two I also wanted to add in at this stage was we can see that those partnerships are increasing their focus on population health, looking together about how we use resources, clinical leadership, and the connections with communities to increase the benefits to local populations, improving their health and well-being. And we're seeing that in the way we talk about primary care networks and neighbourhoods. The other element, and we demonstrate it around the table here, is the need to take some decisions together at a Lancashire and South Cumbria level, whether that be on policies or programmes of work, where we can demonstrate that actually there's been a fragmentation of approach and we will achieve more benefit if we work together. So there's a number of things in scope, and the case for change sets that out in more detail for you. The leaders' workshops also were minded that we were also thinking about how we respond to the NHS long-term plan, which was published 12 months ago, and that indicated that typically, that was an important word, typically there would be one CCG for the Lancashire and South Cumbria footprint. So you'll see in the cover paper in section 2.2, as we began to talk about the potential options for responding to all of those things, we identified a number of options and a number of criteria to judge those options. Tackling inequalities, improving outcomes for patients, getting our resources and capacity in the right places, whether those were in neighbourhoods or in ICPs or working together, and so on and so on. So there are 6 options laid out in the case for change. It's a case for change and option appraisal document, but there is a recommended option in the paper, and it recommends a single CCG for Lancs and South Cumbria, but really importantly, discharging its functions through place-based commissioning teams, locality-based commissioning teams that continue to work in Fylde Coast, Morecambe Bay, Central, and so on and so on. So there'd be 5 of those. It's really important, I think, at this stage, Chair, that I emphasise that this document today only asks the Joint Committee to begin a process of engagement. And again, that's an important word. We're not asking the committee to make a decision today on any particular option. We're asking the committee to begin that process of engagement and actually asking for that to be led by each of the local CCGs. The engagement will be with member practices, with partner organisations, with patient and public groups, and with commissioning staff. So there's quite a wide range of people that we would talk to about this. And it would lay out some of the issues and implications of making any changes as well. So that's really important that I emphasise. The other thing today is to say that the decision, the actual decision on making any changes to the number of CCGs is made by the member practices themselves. That's set out in each CCG's constitution, and it's made by the member practices themselves after that period of engagement and after a vote. So an important emphasis. So based on the discussions that we've had to date, in the paper, in the Case for Change, we identify a number of the proposals and pick out a number of key issues that people have raised as part of this developing dialogue. Issues around governance and leadership and how we make sure we carry on taking decisions as close to local neighbourhoods or places as possible. How we make sure we retain the benefits of clinical leadership, which we've very much concentrated on during the lifespan of CCGs, and we're seeing now in other parts of our integrated care approach. How we address issues around financial allocation that have already been made available to CCGs so that we know how we're using the money, and how we commission services from general practices. So there are particular points in the document that emphasise those issues because we got a sense that they were important to people. Final point, you'll be pleased to know, timescales. The proposals here are that we embark on a period of engagement up until the end of March. So largely carry that process forward over the next several weeks. We will be looking at the issues that come out and trying to respond to those as we're going through, but there'll be an opportunity at the end of that period to look at the outcomes of that process. If member practices are going to vote, we are proposing that to take place in April. And subject to the outcome of that, we would then be under an obligation to make proposals to NHS England. So the CCGs make a request to NHS England. That's the way the process would happen. That would continue through the spring. Any new CCG could not be up and running until April 2021. So however this process unfolds, there is a development period that takes us over the next year and a quarter or so. So that's an important issue to summarise. So really now, Chair, happy to see how colleagues want to respond, deal with questions, and go from there.
I appreciate that a number of members present here have been involved in discussions that have led up to this, but equally this is the first opportunity to discuss at a formal meeting the proposals. So any questions or comments? Richard.
Thank you, Chair. First, just to recognise the huge amount of work that's gone into the Case for Change paper. And certainly I recognise some of the contributions from Pennine Lancs and probably all the CCGs around the table, so I think that's really important. It's something which we've been discussing in Pennine Lancs for many months, but we haven't as yet reached a consensus on this. So as such as I'm representing their views, they haven't seen this most recent version, they haven't had a chance to vote on that given there's no consensus. And so that concerns me a little bit about today, and I think in terms of the way things are worded, I would have to abstain in terms of endorsing or approving this. And that's partly because some of the questions that they're asking are quite important to them. Some of it's about the financial modelling work, I'm sure, which has been done, which might be able to be shared, and explaining as much evidence as we can for that. And then one of the key issues is partly about how that local commissioning team will work and will look at. And whilst we've talked quite a lot about the sort of structural form here, colleagues are very interested in functions, in how we carry those out locally, and then what that means for them and their roles, and ultimately the citizens that we work for. So they're the main concerns. Given that it will take a little bit of time to have further discussions at governing body, and perhaps even wider still across Lancashire and South Cumbria, so that there's a consensus about how an ICP or an MCP should work, I'm just a little bit worried about the timescales. A little bit concerned about having a period of engagement, for example, with member practices, when we haven't yet reached a consensus in governing body. Thank you.
Comment on that?
I'm wondering whether we take a number of comments, and then, because some people might wish to respond to some of what Richard's saying.
Respond, I think we all need to be really clear about the difference between endorsing everything that's recommended in here and the ask, which is that this is the basis of the information that we ask people to take to their local areas to start that conversation. And it's a bit chicken and egg. The more we keep doing work on having all the answers, the harder it will be to start having that. So the ask here is not to approve a final recommendation that this should happen. The ask here is that we go to individual CCGs, partner organisations, member practices, and present this information and start to be able to answer their questions. Because if we keep finalising the answer and then the questions are slightly different when we do start that engagement, we're almost not further on. Does that make sense?
Yeah, it does. Obviously, I wouldn't want to put people in a room with different opinions about how the future may look. You want to give people the most accurate information that you can. That was my concern about starting engagement prematurely when there isn't that consensus.
Okay, any other contributions on this? Oh, Roy, sorry.
Yeah, thanks, Chair. I think it's possibly the terminology that's being used within the paper, Chair, if I might say that. And it's the definition of endorsing a document, and Amanda sort of alluded to that in her earlier comments. And my definition of endorsement of a document is to actually recommend that to other bodies. So if we're recommending, if we're actually recommending this to our governing bodies, to our GP memberships, should we not be saying that instead of... See, asking endorsement almost sounds like it's a done deal, I have to say. And that's the terminology I sort of understand, that particular word. And I wouldn't want that to come across to our governing bodies or our GP membership in that sense. So I think, Chairman, if we could, and Andrew, if we could perhaps change some wording in there that allows us to agree this particular position, including the Pennine group who are here. Because if we don't do that today, and Pennine do abstain on this, I'm sure you're aware that in our rules, in our TOR, we can't agree to this because we need more than 75% of the CCGs to accept this. I think that's really important, and I think we need to come out of here with some sort of answer to this, but I just think that we need some sort of wording that would be acceptable to us all, that we could take back, that could give comfort both to our governing bodies and to our governing and to our membership. And ultimately, it does say in the paper, and we all accept that, Andrew, that you've said in the paper, and it's very, very clearly stated that the GP membership do have the final say on this, and that's correct. But up to now, it's been an iterative process. We need to carry on with that iteration, be able to carry on with that process through our governing bodies, through our GP membership. So I think and that allows us, the paper allows us to do that, but I think we just need to be a little bit clearer on how we're allowing those particular individuals or bodies or governing bodies to be able to do that.
Jeff. Jerry, sorry.
I'm going to caveat this. I am not a lawyer, but I did write the terms of reference. The latest terms of reference are very clear about the responsibility of this group to take leadership for the commissioning reform work. It has actually sets out very clearly that in things like case for changes, this is the responsible body, and there's a very clear reason for that, and that is if we keep going back out to individual organisations to approve every form of case for change or engagement document, we will actually be here in 5 years' time trying to do this. It does very clearly differentiate, though, that the decision remains within the member practices. So the governing bodies have, by signing off the terms of reference, have agreed to this committee making the decision on the case for change and the engagement process. Now, I stress, I am a lawyer, and if you don't want to agree with that, I'm sure you can find a lawyer who will find a reason to say that. But there is an absolute message in this that as a leadership team and a collective leadership, the expectation is that we should be able to use this forum to have a single agreement about a document to engage with our member practices. I think the answer is to this one is, and again, it's a bit like Amand's comment, is the danger is we will spend forever trying to answer questions that everybody will continue to have a differing view on. The most important point to this, for me, is that we have a consistent story to take out to all the practices, to enable all the practices to feed back their concerns or not concerns. The longer we delay actually talking to the practices, then the longer it is we will take to get a consistent view back from the practices. So I should emphasise again, repeat the thing, the case for change here is about setting a standard language to go out to the practices.
Are there any other comments? Paul and then Jeff.
Yeah, thank you, Chair. I think I would certainly concur with what Richard and Roy said, and I think it is maybe the language. I mean, my understanding of the word endorse is to publicly approve, and I don't think we're publicly approving in that sense. I think in terms of our understanding, as opposed to what Jerry said there, was that our expectation was the case for change would be developed here, and there would be a recommendation of a case for change from here, that would go back to governing bodies, who would then approve the case for change before taking it out to membership. Because if we don't have the governing bodies approving that, then the membership will be asking the question, has the governing body approved this? And if it hasn't, I'm not sure that will carry the weight that we would want it to do. So we might be getting wrapped up in words with this, but I think the wording is very important, and what we're being asked to do is equally very important. So I think we need to clarify that.
Andrew wants to speak before Jeffrey comes in, if that's okay, on that specific point, those points.
So I'm not a lawyer either, but I do think the sentiment that you and Roy and Paul have been sharing is actually the sentiment that was behind the recommendation, because of the clarification of who actually takes the decision. So if this word endorse is an issue, it's quite easy for us to consider an amendment which says agree to use the case for change document as the basis for local governing bodies to lead a period of formal engagement. Agree to use the case for change document as the basis for. As the basis for means, Richard, there will be more work developed. We've had a really useful session this week on functions, and how we might describe the role of a locality commissioning team. That needs to be in the engagement material as well as the case for change. Speaks to your point. Agree to use the case for change document as the basis for local governing bodies, so it lands it with the local governing body to lead the process of engagement, which is where, as Roy has said, we think it needs to be led out of. So I don't know how that responds to some of those comments made.
Well, you're thinking about... Oh, Rich, you want to...
Yeah, just to add, I guess it's trying to be as... you don't want to spend too long discussing this, but if people are asking for the information to be a little bit more comprehensive than it's phrased, it might influence their decision to approve or vote or whatever they choose to do. So that's why I'm obviously getting clear messages from governing body members that this is important to them.
Okay. Jeff, thanks for your...
Andrew beat me to it. This is exactly what I wanted to say, but you said it much more beautifully.
Okay. Anybody else want to comment on this?
Yeah,
Roy and then Jeff. Or other way around.
I'm really mindful that
Sherry.
any engagement with member practices that doesn't have the implicit, explicit support of the governing body is going to be a dangerous process. So you've got to take the governing body forward with you. I will go back to the point. The whole point of this committee is to make sure that when we go out across Lancashire and South Cumbria, we have an agreed approach. So the one caveat I would be careful of is it is right to go back to our individual governing bodies, but we need to be really careful that individual governing bodies don't say, but we'll change that case for change and we'll change the recommendation and we'll change the message because we think this is better for our practices, because that's going to be a very quick way to undermine the role and responsibilities of the Joint Committee. So I just want to emphasise, I think there is a leadership element here to say that we need to take governing bodies with us, but also we need to make sure that as a leadership across Lancashire South Cumbria, we are taking a consistent message out to the member practices, because nothing will undermine this process quicker than collectively as leaders, us all taking out a different story and a different message.
Roy.
Just probably to respond to that, nothing will undermine this process more than us setting a fait accompli. We don't want to go out there with something that we say this cannot be changed, this cannot be in any way resolved by any of the governing bodies or any of the member practices. I think it'd be wrong for us to say that. I think Andrew's words do soften the original resolution of the paper in that asking for endorsement and I say it's that definition of that word. I think it's difficult. I don't suppose we get probably 20 different comments around the table about what that word means. I understand, Jerry. We are leaders within our own organisations. We have met, as Andrew's rightly said, to discuss this as chairs and as chief officers. And as I said earlier, it's an iterative paper, and we have made changes to this paper, and we have actually wrote to Andrew to say that to ask for some of the changes to be included, and those changes have been included. But conversely, those changes have not been before our governing bodies. So I think it's really important as well to say that, yes, we're bringing it back to the JCCG as a paper that's been agreed by chief officers and chairs, and yes, we would agree that goes out to that engagement and consultation with those appropriate bodies. But what I believe we cannot say is that cannot be changed. I think we have to accept that there may be comments, different comments and different points that will be made that might change this paper. Not materially, I believe, but it may well change this paper. Now, if we don't give that option, I think we're at risk of saying we're going to set a fait accompli.
Amanda.
So I think there's a difference between changing the recommended outcome and changing the paper. I think there's a danger if 8 CCGs go and everyone changes 2 sentences and we end up with a different paper being agreed or not agreed everywhere. So absolutely, we're not endorsing what the outcome and recommendation should be, but we can't start changing bits of it differently. The other thing, and I don't want to make myself unpopular here, but we need to think really, really carefully here, because with something like this, where regardless of the very, very strong national steer, there's quite compelling reasons for looking differently at how we commission. I think the case for staying the same has to be as compelling as a case for change. And I think we have to ask ourselves as a committee really carefully, have we got the right to take a decision which stops the people responsible for this, which is our member practices, from being engaged, being exposed to the case for change and the options appraisal, and having the discussion and making that decision. And if this committee says, no, we don't want this case for change to go to the people whose decision it is and talk about it, when every single person in this committee has a conflict of interest, I think we're doing our population a disservice. Our member practices Whether or not they agree with proposals or the various options, that doesn't matter. Our member practices who are responsible for the health of our population as members of CCGs have an absolute right to listen to and consider and comment on this and make the decision. And I think we've got to ask ourselves really carefully that if we are looking at stopping that from happening, which if we don't agree to take the information to our member practices, we are doing.
Okay, anybody else want to comment? Jeff?
I don't think the discussion document's that important in this sense. It's a discussion document. It's not a policy. It's not an agreement. It's something to get people talking about. And actually the bit that matters, and it won't matter to our governing body, I don't think, in Morecambe Bay that, because they will discuss it, but the real meat is, do we go for one CCG? And which or which are the other options? And we'll never get there unless we start the process. And we can't keep stalling. So we need to get that discussion out to the member practices. And the discussion document, people can rubbish, tear to bits or whatever they like. It's one committee's view of the world, but it's actually what the members say at the end of the day, and we need to get the ball rolling, really.
Any other comments on this? Yes, Dennis?
Unlike me, I'm going to make a really simplistic comment now, because I'm just going back to Andrew's point. I think you explained it really well. What I think what we're being asked to do is to approve a process of formal engagement with the members. Full stop. Zero, nothing else. Now, if we take that, what is there to disagree with? We're not making a decision for them. They're going to make the decision. We're asking them to consider information and make a decision. So is that what we're asking this group to do? To approve the fact that we're going to go and ask members to make a decision? If that's it.
So absolutely, my only caveat to that is to do that using this case for change document, so that when we go out with the same document with the same story. Clearly all the changes or differences of opinion and saying I don't like the document, that all comes out through the engagements. But at least we are, as a committee, saying we will go out with one document to use.
Gavin, sorry.
Yes, thank you. I think what I'm hearing is that nobody's actually really disagreeing with the caveats that I've heard being put in by Andrew. I think the points you initially made, Richard, were that you would have some concern that there may be people within your particular group who, having viewed this, wouldn't agree with points within it, but wouldn't be refusing to view it and be engaged with. And I do think it is important to know the definition of the words, and the definition of endorse is to offer public approval of something or support, not the fact that you're saying this is how something will be. I think as a committee and as a group, you are being asked, do you, as members of this group, offer your public support to follow the plan of that engagement? So I'm not really hearing anybody at complete loggerheads. That's my view.
Chairman, I agree with what's just been said. I think we're trying to all find a way forward here, and I think we're just trying to find words, and some words are acceptable to us all. From Andrew, you suggested some, that can allow us to take this back, as Jerry's rightly said, as a document from us that goes out to a number of bodies for discussion and ultimately, hopefully, agreement. You referred to earlier, Andrew, the timescale, and you'll know that I wrote to you about the timescale and said I was concerned that I thought it was very tight, and that in fact I believed we should have brought that consultation and engagement forward, because you referred to in the timescale it was February to March. I thought actually we should have started that timescale perhaps now. And I think if we actually support the paper today, that gives us that opportunity actually to bring that timescale slightly forward and start those discussions as early as possible with our member practices, with our CCGs. And I think the more time that we have, the more opportunity and time that we have to do that, then the better, I think, for this process.
Thank you, Roy. No disagreement with that point. And let's not forget that the process that we've used to get to this point has involved conversation with a large number of people. And the range of contributors to get the document into this format has again been a product of listening and further development. And I think that will continue. I mean, I think what I was trying to imply earlier, to give you some reassurance, I think is that we will expect that some of the developmental aspects of this will come through as part of the engagement process. Remembering that we've had change in our commissioning system over the last 5 years anyway. We've had boundary changes, we've had shared management teams, we've got those processes, and we've got this dialogue going on within local integrated care partnerships about how commissioning evolves anyway, to the point where some people don't want to use the word in quite the same way as we have historically. So there's been a constant process of change, and this isn't in one sense a huge shock to the system. It has to deliver that progression of integrated care development, otherwise it's not going to achieve what we set it out to. But certainly we've written this, refined it, we've had some further development work this week, and we would expect to build some of that into the engagement that goes out, and I think that will continue, but no problem with getting on with it.
Could you just indicate, sorry, we're all coughing today, again, Andrew, what your suggested rewording would be, and then we could perhaps ask Richard, if he, having heard what he said and listened to what we will put to the vote, whether he'd feel able to support it.
So there was a concern about the interpretation of the word endorse. A number of you made that point. So when I was reading out, I was making the direction of the recommendation to be about the use of a consistent document through local governing bodies as the basis for this process. So agree to use the Case for Change document as the basis for local individual CCG governing bodies to lead a period of formal engagement from February-March 2020, and then the recommendation carries on as it's drafted at this stage. So it's a change to the beginning of the sentence.
So if I could ask you directly, Richard, would that likely to be satisfy you that you could support?
Yeah, I think I'd be happy with that rewording.
And I just hope everybody else will got to that point. Right, so I think it's right now that we take a vote along the lines of the wording that Andrew has just put forward. All those in favour? Is anybody against? No, so that's carried. Thank you very much.
Thank you. So then if I move to the second part of the document, there is an introduction to it in the cover paper and then a set of terms of reference. Recognising that this is a significant process, there are a range of issues, we're bringing proposals to reorganise an existing group that we've had in place for about 18 months or so, to coordinate some of our thinking on commissioning development and to make it more clearly accountable to the Joint Committee of CCGs, and doing that by renaming it, making some proposals about a refreshed mandate and membership. So we would use this group effectively as perhaps to do some of the diligence that colleagues have been calling for around the table as the process develops. We had a conversation in a recent meeting about the potential to appoint a vice chair for the Joint Committee, and one of the proposals here before you is that the vice chair could play the role of chair of this particular subgroup. Again, this would be one of the places where we would do significant oversight work of any agenda we have going forwards. So I'm asking the Joint Committee in this case to receive those terms of reference and agree that we constitute it as a subgroup of the Joint Committee.
Okay, any questions, comments on this? Around? Jerry.
Just welcome the development of this committee. I think it's a really important part in terms of supporting the Joint Committee in its decision-making moving forward. It's just a point of clarity, I suppose. It's just a recommendation that where it says one CCG executive acting as a representative from each ICP, that we try to make sure we get a blend of executives just to ensure we've got a richness of executives. Nothing could be worse than 5 AOs on that group.
Worse.
Quote unquote.
All right. So I mean, Is that a recommendation, or do you just want it to come?
It is a recommendation or a request that perhaps when the Vice Chair is there, that he encourages the ICPs to nominate different types of executive representation.
Okay. Yeah. Right.
Yeah, thank you, Chair. Just to say, Andrew alluded to the Vice Chair, and there is a process now in place in train to actually nominate that individual, probably towards the end of this month, I would suggest.
Okay. Jeff?
Just to understand the terms of reference, what's the change in membership from the old committee? Who have you lost, or has it just expanded, or is it?
We have the chair would be an addition. Yeah. We have typically had executives from each of the areas.
Right.
Having a governing body clinician or lay member would be important additional membership.
Yes.
But largely then, I think there's also a specialised commissioner. We do get SpecCom. So those are the main changes.
Okay, thank you.
Thank you.
Okay, any other comments, questions? So with those recommendations as outlined and adjusted, if you like, are we in favour? Yes? Anybody against? Thank you very much. We have one item of any other business from Amanda.
And it's very closely related to those things. It's really just a heads up. So as well as the commissioning reform work we've talked about this afternoon, people will be aware that we've also been doing some quite significant work about mental health commissioning. We've done a review of mental health commissioning and learning disability commissioning. And those are, those things are coming to a conclusion and are really part of our commissioning reform work. It includes the whole picture. But we are coming under a lot of pressure around learning disability services and the pathway because we are such a significant outlier nationally. And so we're going to have to take some decisions in a way which almost preempt completion and approval of the Learning Disability Commissioning proposal, in that we're going to have to take decisions once much more quickly than the current 8 CCGs and 1 joint committee can currently take. So it's really just a heads up that for a couple of decisions with regard to learning disabilities, we will almost be coming back for approval. We won't just be having the learning disability team taking the decision. We'll be involving AOs, involving the relevant groups of people where we can get them, but we may have to take some decisions in advance of 2 months' time for the next formal meeting of this board. But that will be because of urgency around decisions in the interests of our patients. So it's a heads up. Nothing will be decided that isn't then brought back, and any opportunity to use other groups with the relevant people there will be used. Happy to take any questions or concerns about that.
Okay, are there any?
It's part of rapid improvement in specific areas rather than trying to make decisions without formal process.
Okay, content with that, I think. Yes, thank you very much. So the next meeting is on Thursday the 5th of March, same time, 1 o'clock till 3 o'clock. The venue still to be confirmed. Thank you for that. So I'll now close the formal part of the meeting, and we'll now leave the live streaming. Thank you. We now have an opportunity for a member of the public, Jenny, who's been with